Today we are presenting a lecture on spontaneous bacterial peritonitis. These are the learning objectives. By the end of the session, the learner should be able to understand the pathophysiology of spontaneous bacterial peritonitis, or SBP, clinically recognize which patients are likely to have SBP, list the common organisms responsible for SBP, appreciate the severity and consequence of SBP and the importance of timely treatment, prescribe the appropriate treatment for SBP, and lastly, be aware of the indications for SBP prophylaxis in cirrhotics. What is spontaneous bacterial peritonitis? The definition is an acidic fluid infection of polymorphonuclear neutrophil count of more than or equal to 250 cubic milliliters without an evident intra-abdominal, surgically treatable source of infection. The pathophysiology of SBP is a pathological bacterial translocation of enteric bacteria across an edematous bowel wall via mostly lymphatic routes. In the setting of advanced liver cirrhosis, there are several changes, such as 1. Alterations in gut microbiota, whereby increased prevalence in pathogenic bacteria and changes in fecal microbial composition develop. 2. Increased intestinal permeability due to structural and functional alterations in the intestinal mucosa. 3. Impaired immunity due to a marked reduction in opsonic and bactericidal activity in cirrhosis. Therefore, SBP occurs due to enteric bacterial translocation across an edematous bowel wall in a cirrhotic patient with reduced immune function. When should you suspect spontaneous bacterial peritonitis? You should suspect it in a patient with background of cirrhosis and ascites, presenting with symptoms of fever, nausea, vomiting, and abdominal pain, as well as perhaps diarrhea. Signs of SBP would include abdominal tenderness found in around 40% of patients. Rebound tenderness is rare. Acidosis, azotemia, and hypotension. The diagnosis of spontaneous bacterial peritonitis is defined as acidic fluid polymorphonuclear leukocyte or PMN count more than or equal to 250 cubic cells per cubic millimeters, or an acidic fluid white count of more than 500. Abdominal paracentesis is performed to establish the diagnosis and also differentiate between primary from secondary spontaneous bacterial peritonitis. Secondary SBP is an acidic fluid infection caused by a surgically treatable intra-abdominal source due to either a free perforation of viscous or loculated abscess in the absence of perforation. When a diagnosis of SBP is suspected, a diagnostic paracentesis should be performed as part of the initial septic workup prior to the commencement of antibiotics. The acidic fluid should be sent for the following investigations: cell count and differential, gram stain, and culture. Occasionally, a positive acidic culture occurs in the absence of an increased acidic PMN count. This is called bacterial ascites, which occurs in up to 2 to 3% of outpatients and up to 11% in hospitalized patients. In secondary SBP, there tends to also be multiple organisms cultured, including fungi and enterococcus. Albumin and total protein, glucose, lactic dehydrogenase, amylase, TB, and cytology investigations. If any unusual sources are suspected, such as mycobacteria, then an acid-fast bacterial smear and culture should be ordered. Or, if one was suspecting peritoneal carcinomatosis, then a cytology should be ordered. Other relevant investigations include full blood count, looking for raised total white cell count, urea, creatinine, electrolytes, liver function tests, blood cultures, as well as imaging to exclude alternative causes of intra-abdominal abscess. So, why is spontaneous bacterial peritonitis so crucial to identify and diagnose early? Because there are several consequences to SBP. In hospital, mortality for the first episode of SBP ranges from 10 to 50%, depending on risk factors. The occurrence of SBP or other severe bacterial infections markedly worsens the prognosis in patients with cirrhosis. Some of the consequences include septic shock, with acute circulatory failure due to persistent arterial hypotension as a result of the vasodilatory response caused by widespread infection. In hepatorenal syndrome or HRS, reversible functional renal impairment that occurs in patients with advanced liver cirrhosis or fulminant hepatitis who have portal hypertension and ascites. The hallmark of HRS is intense renal vasoconstriction with predominant peripheral arterial vasodilation. Estimates indicate that at least 40% of patients with cirrhosis and ascites will develop HRS during the natural history of their disease. It is divided into type 1 and type 2 hepatorenal syndrome. Type 1 presents with rapidly progressive renal failure with doubling of serum creatinine, with extremely poor prognosis of mortality rate as high as 80% in 2 weeks. SBP is the most common cause of HRS type 1. Type 2 HRS arises spontaneously, is slower in onset and progression, associated with portal hypertension and diuretic-resistant ascites with better median survival. Consequently, the patient might also develop decompensated cirrhosis, where there is hematological manifestations such as coagulopathy and anemia, hepatic encephalopathy, variceal bleed and portal hypertension, deranged liver function enzymes, jaundice, and ascites. In the management of spontaneous bacterial peritonitis, the recommended antibiotic regimen for treatment of SBP is IV cefoxitin 2 grams every 8 hours or a similar third-generation cephalosporin for 5 days, or oral ofloxacin 400 mg twice daily for 5 days. This regimen will cover for the following organisms commonly known to cause SBP: E. coli, Klebsiella pneumoniae, and Streptococcal pneumoniae. Singapore General Hospital antibiotic guidelines recommend the following treatment regimen: IV augmentin 1.2 grams every 8 hours for 5 days, or IV ciprofloxacin 400 mg every 12 hours with or without IV gentamicin of 5 to 7 mg per kilogram once daily for 5 days. If cultures are negative and patient is symptomatically better, this can be reduced to oral augmentin 625 mg every 8 hours for 5 days. Patients with acidic fluid polymorphonuclear counts less than 250, but has signs or symptoms of infection, for example high temperature, abdominal pain, or tenderness, should also receive the empiric antibiotic therapy while awaiting results of culture. In addition, IV albumin infusion has been shown to decrease mortality from 29 to 10% when used together with the above antibiotic regimen. So what can be done to prevent spontaneous bacterial peritonitis? Primary prophylaxis refers to a patient who has not had SBP before, but has an increased risk of SBP due to acidic fluid protein concentration less than 1.5 grams per deciliter, together with either impaired renal function or liver failure. Impaired renal function defined as follows, and liver failure classified as follows. Long-term prophylaxis is recommended with norfloxacin 400 mg daily or ciprofloxacin 500 mg daily or Bactrim 2 tablets daily. Cirrhotic patients with variceal or gastrointestinal bleeding should be treated with IV ceftriaxone 1 gram every day or oral norfloxacin 400 mg twice daily for 7 days to prevent development of SBP. For secondary prophylaxis whereby one or more prior episodes of SBP has occurred, patients should be maintained on long-term prophylaxis with norfloxacin, ciprofloxacin, or Bactrim. This is important because recurrence of SBP has been reported up to 69% per year. Intermittent dosing of antibiotics to prevent bacterial infection is inferior to daily dosing due to development of bacterial resistance, and thus daily dosing should be preferred. In summary, spontaneous bacterial peritonitis is the most frequent bacterial infection in cirrhosis, accounting for up to 30% of all reported bacterial infections in hospitalized patients. Yet signs and symptoms are frequently absent in patients with SBP. Therefore, it is crucial to recognize and treat SBP early, as it carries a high rate of mortality and also markedly worsens the prognosis in patients with cirrhosis. Early diagnostic peritoneal tap is an important component in the septic workup in a patient with suspected SBP. Here are a few key references for further reading.